You may unmute and confirm to me.
Yes, sir.
Everything visible? Everything audible?
Yes, sir.
Okay, good. There are only 25 students so far online. What's happening? Hmm? At 2 o'clock, a class in college can be understood that you got delayed for lunch. But at home, I think you all should join in time. Hmm? Please convey it to all your friends that punctuality is very important. Right. We'll start now. We had a discussion on rheumatic disease and rheumatic heart disease. And in that, we had posed some questions to you. One of the questions was on this cervical lymph nodes, which lymph node drains into which area, or which area gets drained into which particular lymph node, so that by figuring out which lymph node is involved, you can make an intelligent guess as to the primary site of infection or disease. This is very important for all lymph nodes because each lymph node specifically drains a defined area. So your knowledge about lymph nodes and their draining area is extremely important to localize the disease site. So you all need to practice that. Second question which we had asked was why there is no vaccine against rheumatic disease or rheumatic heart disease specifically, because that is the long-term more deleterious consequence. Some of you have written answers. Some of them have written very well, very interesting answers. And some of you have totally missed the point. So go back, think about it. Those who have written answers, I suggest you hold on your horses. Don't discuss it with your friends so far. Let others also write down their answers, their guess as to why there is no vaccine against rheumatic disease so far. What is the reason for that? And maybe next week or so, once hematopoietic system is over, then you can discuss amongst yourself and work out the reason for that. Now we'll move on to another chapter, that's bacterial endocarditis. We had a class on last week, but because of the net problems, we could not conduct that. So I have truncated that class and mixed into today's class because some part of it has already been covered by the pathologist. I hope they have covered endocarditis. Did you have a class in pathology on endocarditis?
Yes, sir.
Okay. So we'll just quickly go through that. What do you see over here in the picture? Beautiful foliage, orange, reddish, blue, orange, reddish, yellowish in color, maybe autumn or maybe it is a sunset. So it's reflected over there. And I used to go for walks in the evenings towards lakes, towards our riverside. And there I met one young, beautiful lady, Sandra. So we are going to tell you the story of Purple Heart Sandra. She's a 25-year young cine star, and there is a big house on that road where she was staying for a few days because they were shooting for their latest movies. And they were there for almost a month or so. So whenever in the evening I used to go for a walk, we used to say hello to each other. And one day she complained to me that she has got low-grade fever, nausea, anorexia, and weight loss since 5 weeks. She noticed it more since the time she had come to Pokhara. So I asked her, is it because you don't like the weather or you're not getting good enough food? She said, no, weather is wonderful, much cleaner than Kathmandu. But I'm having anorexia and I noticed I have lost weight despite eating well. So we called her to the clinic and we checked that she had mild fever, she had anemia, and she had clubbing of the fingers. On detailed examination, we found she had splenomegaly as well. So this picture, young lady, low grade fever, nausea, anorexia, weight loss in 5 weeks time, anemia, clubbing and splenomegaly. Does it tell you anything about a system, or does it tell you about a site, or does it tell you about a pathological process? Any guess? Splenomegaly. Splenomegaly, commonest causes of splenomegaly. Anyone? Can anyone unmute and say what are the commonest causes of splenomegaly? I think hematopoietic system, the pathologists have told you about it. Any guess? No guess? That's surprising. That means you people are not paying
Sickle cell
attention to the text.
RBC or
Yes,
excessive hemolysis.
excessive hemolysis or
Sickle cell RBC that clump
sick-
block the lumen.
sickle cells. Anything else? Any other commoner disease in our country? Sickle cell is not so common in our country. Malaria, yes, very important, malaria. But luckily, in Pokhara, we don't have malaria. But malaria can lead to fever, nausea, anorexia, weight loss, and splenomegaly. But it does not lead to clubbing. So, those splenomegaly suggested malaria or sickle cell anemia. That can explain anemia also. But clubbing is not explained. What is clubbing? Anyone knows about clubbing? In ICM classes, they must have taught you about what is clubbing. It's something to do with fingers, nails. Okay, so
Of
one,
fingers,
yeah,
that is bulbous enlargement.
bulbous enlargement of the fingers. Okay, so it's now for everybody to find out what is clubbing, what is the etiology of clubbing, what is the pathogenesis of clubbing, what are the clinical conditions in which you see clubbing. Because each of these clinical signs and symptoms which I am mentioning should give you some clue to the underlying disease pathology, and you should be able to make a clinical diagnosis. So find out cause of splenomegaly. You have ruled out malaria, you ruled out sickle cell anemia. Now find out cause of clubbing and see which of the causes go together, explaining that particular disease. So what it shows is that there is some inflammatory process going on in the body, most probably, because it has led to more of a generalized symptoms and signs, not localized to any one system. It's involving anemia, that means involving bone marrow, clubbing, that means involving fingers, and causes which you will know about it. Nausea, is it abdominal system? Fever, fever is perhaps the most important. Anorexia, nausea, and weight loss could be linked to intestinal symptom. But this way, it means that whole body is involved. When you say whole body is involved, we call it as a some systemic condition. We checked her oral hygiene because that is important. In case person has bad oral hygiene, it can lead to anorexia, nausea, weight loss. She had excellent oral hygiene and she said, oh, she flosses her gums and teeth regularly every morning, evening because she has to present in front of camera and give a wide, big smile for toothpaste advertisements also. So she was taking care of her oral cavity also. Well, we were nowhere. We tried to examine the rest of the body, lungs. There was no abnormality in the lungs. There was no abnormality in the abdomen. When I looked at fingers, I found there were some small spots like this, reddish spots on the pulp of the fingers. So we thought, let's do some investigations. Our clinical diagnosis of anemia was confirmed with low hemoglobin, but RBCs were normostatic, normochromic. That means it excludes hemolytic anemia, it excludes iron deficiency anemia. So normocytic, normochromic RBC. In other words, now you need to have one more homework is find out the causes of normocytic, normochromic anemia. TLC was high with polymorphonuclear leukocytosis. Now high TLC indicated inflammation. Platelets were within normal limit, though we saw some kind of a hemorrhages under the pulp. Urine RE and culture was okay. No abnormality detected. Any woman presenting with fever, there is a likelihood of urinary infection. So we must undertake urine RE and if required, culture also. And ECG was done, and since it's appeared to be a prolonged period of chronic inflammation, we took a blood culture also. Her echocardiography showed some abnormality, so we admitted her in the hospital. And in hospital, she developed tachycardia, arrhythmia as confirmed by ECG, and the chest physician who examined her chest found some murmurs. An ECG was done, which showed lots of abnormalities. So now we are perhaps finding something wrong with the heart, but at the same time something wrong with the rest of the systems also. She suddenly complained of acute chest pain. Everybody rushed to her. She was a big cine star. Everybody in hospital, all nurses, all doctors, all interns, all students wanted to be with her to take their selfies. But suddenly she developed chest pain. She was moved into ICU. But before we could do anything much, she collapsed. Unfortunately, she died. What do you think might have happened in her? Young, spirited person suddenly develops all these problems, comes to hospital, and despite our best efforts, while we are still investigating to find out her cause of death, she dies. Well, it happens sometimes. Everybody who comes to a hospital does not necessarily get well. We have to accept this fact of life. We have to ready ourselves also as doctors to deal with deaths and people dying in the hospital. Most of the time when we expect them to, but sometimes unexpectedly also. Since it was sudden death, post-mortem examination was called for, and at post-mortem, this is what we saw in her heart. Can you see this irregularity of the heart valves and some roughening over here and some growths over there? You can see some vegetations on the mitral valve. So what does it indicate? Any guess? What would be your diagnosis after postmortem, keeping in view all the clinical features? Can anyone unmute and suggest? Anjali? Vigya? Pratishma? Anyone? Ranju? So many of you are there. What do you think could have happened? Bimla? Young lady coming into hospital, lying with all these presentations. Well, the postmortem revealed that she had died of infective endocarditis. So infective endocarditis is not only a theoretical problem. It's something which happens in our hospital even today. So let's look something about infective endocarditis. How do you define? Uh, when we say infective endocarditis, when you say itis, we normally tend to say that it's an inflammation of the endocardium, but it is a misnomer. In this case, there is no inflammation of the endocardium. Everything which is happening on the surface of the endocardium, not inside the endocardium. So it's a misnomer to call it endocarditis, but the name is stuck because of historical importance. What happens actually is there is a proliferation of microorganisms on the endothelium of the heart and the valves. So there is no inflammation, there is proliferation of microorganisms on the surface of the endothelium of the heart or on the endothelium lining the valves. So obviously, every part of the heart, wherever there is endocardium, can get such bacterial or such microorganisms proliferation. The commonest sites are all the heart valves, interventricular septum, the chordae tendineae, the mural endocardium, and if the patient has been fitted with an intracardiac device, even that device can be a place for proliferation of microorganisms. So that's a definition: proliferation of microorganism on the endothelium of the heart and its valves. No inflammation. I am sure the pathologist must have shown you, an anatomist must have shown you lots of diagrams of the heart. So these are all the four valves. So all four valves can be involved, but sometimes it's common in mitral valve and tricuspid valves. But aortic and pulmonary valve also can be involved. And depending upon the progression of the disease, though we will call it endocarditis, it is called acute endocarditis or subacute endocarditis. Acute proliferates much faster, subacute little slower. Depending upon the anatomical problems, endocarditis are also classified as native wall endocarditis, where the heart valve is normal, or prosthetic valve endocarditis, when a prosthetic valve is attached, or a different types of endocarditis where IV drug abusers are more involved. So it is called IV drug abuse endocarditis. So native wall, prosthetic wall, or drug abuse related endocarditis. That's another classification. So there are two important classifications based on prognosis, acute and subacute, and based on type of valve involved, native, prosthetic, or in drug abusers. So as we discussed, any surface of the heart, it may be valves, it may be chordae tendineae, it might be interventricular septum, it might be any other portion, it can get involved. But the commonest being the valves and the interventricular septum. So as you have seen, the valves and the interventricular septum, primarily of the left ventricle, are most commonly involved in bacterial endocarditis. Why does bacterial endocarditis occur and how often it occurs? It doesn't occur in everybody, only small percentage of people. Sometimes there is something wrong with the heart itself. There is something in the heart which allows the microorganisms to get attached to it. Our heart keeps on pumping 24/7 throughout our life, but we don't see endocarditis happening in everybody. That means there must be some reason why endocarditis occurs in some people. So let's see what is there associated with endocarditis related to cardiac activity. Rheumatic heart disease in our country is the first and the commonest predisposition for endocarditis. As we had seen in earlier class, in rheumatic heart disease, the structure of the heart gets damaged, the valvular surface gets damaged, the chordae tendineae gets shortened, the valves don't close properly, and it leads to turbulence of the blood over there. And such rough surface allows the bacteria, allows the microorganisms to get lodged onto them. If you look at a drain which has been kept clean, tidy, and clear of debris, the water will flow through it very easily, smoothly, without causing any problem. But a drain where the walls of the drain are damaged, they are rough, or there is some projections coming out of that, that drain will not allow water to flow clearly, properly, at adequate speed, but will cause local turbulence. That turbulence, that revolution of the water, that disturbance in the flow of the water, what occurs in the drain is similar to what occurs in the flow of blood in the heart when there is some structural damage, like in rheumatic heart disease. So the blood is now, instead of flowing in one direction, is churning, revolving, rotating, causing turbulence over there. And whenever there is a turbulence, there is slowing of the blood flow. With the slowing of the blood flow, the platelets and sometimes the bacteria which are present in the bloodstream may get chance to get attached to the damaged, roughened surface of the endocardium or the valves or the intraventricular septum. And that is what happens in rheumatic heart disease, that the surface is roughened, surface is crumpled, surface is coarse, and it provides numerous gaps in the folds where the bacteria can get attached. So rheumatic heart disease is the commonest cause. Next common cause is congenital heart disease, because in congenital heart disease also there is structural damage to the heart. Maybe there is an interseptal hole, maybe atrioventricular, or maybe ventricle, or maybe there is a patent ductus or any other abnormality in the heart. Maybe a heart which should be tricuspid is a bicuspid and is not closing properly, or any other defect which can lead to turbulence, which can lead to occurrence of endocarditis. So congenital heart disease. Next comes is any person where there has been any cardiac surgery, because during cardiac surgery, particularly open heart surgery, the endocardium is cut open, and howsoever good a surgeon might be, he or she is not able to patch and repair it as smooth as the nature does. So some amount of scarring will be there, which can lead to predisposition. So rheumatic disease, congenital heart disease, cardiac surgery, or in patients where there is a prosthetic valve or a device, again related to interference and cardiac surgery. Person who has had previous endocarditis. Previous endocarditis means he or she must have had one of the earlier predisposing factors where it must have led to endocarditis, and endocarditis by itself will worsen the structural damage. Or persons who have had atherosclerotic heart disease. Again, atherosclerosis, as has been taught to you, will lead to roughening of the endothelial layer and sludging or slowing of the blood flow. In other words, if you remember all these factors, you can think that a patient in your hospital ward or a patient in your OPD, when comes with an unexplained fever and features which you have seen earlier, you should think of, is patient having any one of these cases, underlying conditions? Or in other words, the patients to whom you have been treating for rheumatic heart disease, congenital heart disease, or who have been operated upon, or who had come with previous history of endocarditis, you should be aware that they can again get another endocarditis attack. As we see aging population, what is seen in congenital heart disease in the younger child age, the degenerative heart valve disease is seen in elderly group. So people above 60 years, above 70 years, above 80 years, those who have had chronic hypertension or CCF are likely to have degenerative changes in the valves, and also can suffer. So from birth, childhood, surgery, young age, previous endocarditis, aging into atherosclerosis and degenerative heart, all these can predispose a patient to endocarditis. These are the cardiac factors. But there are other than cardiac factors also which can predispose to endocarditis. These are, even if the heart is damaged, there should be bacteria coming into circulation and passing through the heart to get attached over there. So what all can cause presence of bacteria or presence of microorganisms in bloodstream can contribute towards endocarditis. So patients who get into transient bacteremia, well, practically all of us get transient bacteremia. A small number of bacteria do traverse through the oral cavity or through the intestine into the bloodstream. Most of those which come from intestine are taken care of in the liver itself. So liver acts as a first filter to eliminate all the microorganisms, but some microorganisms can sometimes bypass it, enter the bloodstream and lead to transient bacteremia. Dental manipulations, extraction, or even flossing can lead to some amount of damage to our blood vessels, and since oral cavity is full of all types of microorganisms, they can gain entry from there. When a person undergoes endoscopic examination, maybe bronchoscope, maybe catheter, maybe any cannula, maybe GI scope, any kind of endoscopy is likely to damage the mucosa, and that can cause breach and allow microorganisms to enter through that breach, get into the circulation. Or a patient who is obviously having sepsis, that means the bacteria and their products are already circulating in the body, in the bloodstream of that patient. So wherever there is a chance of the bacteria or the microorganisms to enter into the bloodstream, there is a predisposition to endocarditis. And when a person who has got already a cardiac condition, in that patient, if there is a non-cardiac predisposing factor like cannulation, dental manipulation, flossing, in case of our purple-haired Sandra, most probably as a child she had suffered from rheumatic heart disease, or perhaps she had congenital heart disease which remained undiagnosed, and on top of that maybe flossing or maybe dental action or maybe something else led to bacteremia, and those bacteria went and got attached onto the heart valves which were already damaged. So that's how the dental and the cardiac and non-cardiac factors combine together to form endocarditis. Now what happens in endocarditis? We said development and colony formation on the valve. Do you feel hungry looking at this sandwich? Well, I think you had your lunch, so should not be feeling hungry. What is there in this sandwich? There is a slice of bread, maybe there is a piece of cheese, another slice of bread, some tomato, some salad leaves, again a slice of bread, maybe a ham or a salami or something. So multiple layers of different stuff occurring over there is what is sandwich. Sandwich between two layers of toast. In bacterial endocarditis, more or less similar thing happens. To start with, there is breach of endothelium, maybe because of rheumatic heart disease, maybe congenital abnormality, degenerative disease, atherosclerosis, previous surgery, or anything else. But the continuity of the endothelium is broken. It has become rough, it has become corrugated, it has become uneven. When the blood flows over there, it causes turbulence. That is the first thing to happen. Because of that turbulence, the platelets which are traveling in the blood get activated and start depositing over there. So the first thing to deposit is a layer of fibrin and platelets, which is the beginning of the vegetation in the endocardium. So it's not inflammation of the endocardium. It's a platelet deposition and vegetation beginning. Platelet and fibrin. Next, because the platelets and fibrins are there, they become sticky places, and so whenever there is a transient bacteremia occurring, whenever the bacteria are passing over that, some of the bacteria may get stuck onto that fibrin platelet combination. So some bacteria while during transient bacteremia get attached onto that. So that becomes an implanting of the organisms. The implanted organisms obviously will start multiply. So they will form a colony. They will increase in number. So this colony formation leads to a layer of bacteria on top of the layer of a fibrin and platelet. Now, if the bacteria are there, they'll secrete their products, maybe toxins, maybe some of the cells will die, maybe something else will be released, maybe peptidoglycans will be released, and all that will attract the inflammatory cells. So the inflammatory cells which are also going in the blood along with them, some of them will get stuck onto those bacteria. So we have got one layer of fibrin or platelets, on top of that is a layer of bacteria, on top of that is a layer of scanty inflammatory cells. Now all this is not very smooth, it's very rough, it is uneven. So any uneven surface will again attract fibrin and platelets. So there is another layer of platelets and fibrin on top of that. And if there is platelets and fibrin, surface becomes further rough and there is further bacterial deposition, further bacterial growth, again further inflammatory cells. So this one on top of other continues like a club sandwich, a toast, an egg, a tomato, a toast, cheese, bacon, ham, another toast, another layer, and this layer upon layer keeps on happening in case of endocarditis also, as fibrin, platelets, organisms, inflammatory cells, more fibrin, more platelets, more organism, more inflammatory cells, and this continues to happen. Now, as it keeps increasing, if you look at that sandwich, if you hold that sandwich total and try to bite into it, some part of it is going to spill out. Some part of it is going to get disintegrated. Something will fall off. That's precisely what happens in bacterial endocarditis also. The vegetation which has formed over there, it's friable because there is fibrin and platelets which are contracting and they are getting digested also. So some part of it that splits out and goes out along with the blood flow. And wherever it goes, it can go and cause embolism. So there is a endocarditis where there is a vegetation which can be considered as something like a thrombus, and then that thrombus gets detached and there is embolization. What must have happened in case of Purple Heart Sandra? Most probably she had either congenital or rheumatic heart disease, and so there was a vegetation formation, there was endocarditis, and that endocarditis was leading to systemic conditions or systemic manifestations in forms of fever, in terms of anemia, in terms of increased WBC count, in terms of anorexia, nausea, etc. And part of that thrombus was getting detached sometimes. Perhaps part of that thrombus which was getting embolized was going into the spleen and causing spleen infarct and damage over there, and deposition, or part of it was going and get deposited into various other body parts and was causing inflammation and changes over there. So that explains most of the clinical features of her. But why did she die? Any guess? What must have led to the death of Purple Heart sender? Okay. Endocarditis explained. But what might have killed her? Killed her so suddenly that she was in the ward, complained of chest pain, and died immediately. Any guess? Anyone can tell us as to what might have happened? Yes? Anyone? You can unmute and tell us your guess. It could be anything. An embolization occurring from either mitral valve or aortic valve or maybe tricuspid valve or wherever, or from the chordae tendineae of a damaged myocardium, damaged endocardium. Where is it likely to go?
Brain, kidney.
Yes. Will she die because of thrombus going into kidney? Such sudden death, complaints of chest pain, shock, and dies.
Brain stroke.
Brain stroke, she should have become paralyzed, but shouldn't have complained of chest pain. Anything? Anything to do with chest pain?
Infarction of heart.
Yes, someone said something.
Infarction of heart.
In which part of heart? It's already, thrombus is already in the heart. So what could have happened? Medicine is mystery. It's like Sherlock Holmes story. You have to keep on thinking, analyzing, finding out reasons and an explanation. So what is it? What can explain her chest pain and sudden death? Chest pain, collapse, death. Any guess?
Heart attack.
Right side vegetation.
Yes. What will happen if there is a right side vegetation?
Embolus goes to in lungs.
Goes to lungs. Yes. So there could be pulmonary embolism if it were a right-sided vegetation. Very good. If it were left-sided, yes.
Brain, kidney, spleen.
Brain, kidney, spleen won't lead to chest pain, will it? Brain, it lead to stroke. Kidneys may lead to pain abdomen. Spleen may lead to pain abdomen. She already was getting something in the spleen. That's why there was splenomegaly. Why did it lead to chest pain?
Sir, it blocked the coronary artery itself.
Excellent, excellent, excellent. Yes. An embolism coming from there went into the coronary artery, most really blocked the common carotid, common artery. Okay? Major artery blockage. And she would complain of chest pain because there is a coronary artery occlusion, reduced supply of blood to the heart, and since the heart does not get its blood, it cannot contract and patient will die suddenly. So sudden death is an indication of embolization, either in the lungs if it is right-sided or in the coronaries if it is left-sided. So post-mortem confirmed that she had coronary thromboembolism leading to death. Sometimes the patient might be lucky and it may not lead to embolization to heart or lung, but may continue in other parts. But over a period of time, the fibrosis and granuloma may occur, and ultimately the vegetation may get calcified. But a calcified vegetation is not cure. The calcified vegetation is much more rough, much more uneven, and will attract more platelets for further deposition on top of it. So once a vegetation starts occurring, it continues to grow on itself. It may cut off, may embolize, remaining portion may again start growing, just like if you snipe out some branches of the tree, but the tree will continue to grow. So this is what happens in case of thromboembolism. in case of endocarditis. Are you clear about the pathogenesis of endocarditis? And are you clear about why patient may die suddenly or may have chronic condition also? So these are some of the pictures which pathologists must have shown you. This is a fibrin deposition. If you look at it, you can see this is the layer of the endothelium, and on top of that, there is layer of platelets. There are some inflammatory cells. There are some microcolonies. These must be the microcolonies of the organisms, and again platelets, and again WBC. And this is picture where there is higher resolution, which shows you all types of cells and the platelets and underlying endocardium. What does this show? What is this game? Are they playing? They look like just falling on top of each other. There is a ball somewhere underneath, or perhaps this fellow is holding the ball and they are jumping on each other, trying to grab that particular ball, making a layer upon layer upon layer upon layer. More or less, this is what happens in case of vegetation due to endocarditis. The ball is what is important, but the bacteria are very little in the vegetation. Very small quantity of bacteria may be there. They might have been dead by the time all these platelets, WBC, thrombus, fibrin, everything gets deposited on top of it. The bacteria might have died. But all these things keep on piling on each other, and that leads to increase in the size of thrombus and sometimes fragmentation of the thrombus, leading to embolism. So which bacteria can cause endocarditis? Well, practically any microbe which can get into the bloodstream, any microbe which can get into the bloodstream and go to the heart, any microbe which can get into the bloodstream, go to the heart and finds a damaged heart valve or endocardium, can get attached to that site. So any microorganism can cause. But we have seen that all microbes are not so dangerous to cause, or not so likely to cause endocarditis. It is not the bacteria which are coming from outside. It is mostly the bacteria which are coming from our own system, either from oral cavity, during dental manipulation, or during flossing, or during when you pick your teeth with the toothpick, or when you are eating something which is rough and is likely to damage your gums and cause a little bleeding. Or it could be the bacteria from your intestine which are getting into the bloodstream, or it could be bacteria which is getting from periphery, from your skin through the injection needles or anything, or a bacteria which gets introduced along with catheter in the urethra into the bladder. Anyone which can enter into the bloodstream can cause, and most of these are endogenous bacteria. So the commonest invaders are cocci, streptococci, enterococci, other streptococci also, and staphylococcus as well as diphtheroids. They all are commensals in our body. Sometimes gram-negative bacteria like Haemophilus or coliforms from the intestine or coxella, or rarely chlamydia can cause. Sometimes, particularly when the patient is having candidial colonization, either the oral cavity or urogenital tract, and is catheterized or is intubated, in that case, even the candida can gain entry into bloodstream and can cause infection. There is another group of bacteria which are not normally present in our body but can cause community acquired native wall endocarditis, which are called as a Hassek group of bacteria, which includes Haemophilus species, Actinobacillus, Cardiobacterium, Eichmilla, and Kingella. If you can't remember all these names, just remember this acronym Hassek. That's good enough. So etiology, commonest is Streptococcus viridans, other streptococci, maybe enterococci, maybe staphylococci, maybe diphtheroids, maybe Haemophilus, E. coli, Coxella burnetii, and in community acquired type, it could be Hassig group of bacteria. The nosocomial native wall endocarditis is occurring due to bacteria coming through the catheters. Maybe urinary catheter, maybe endotracheal intubation. Now in COVID cases, lots of patients in COVID are intubated and they may get into bacteremia and they can land up into endocarditis. Prosthetic valve endocarditis usually occurs because of peroperative contamination. If the surgeon or the surgical team has not been scrupulous enough, they can inoculate Staphylococcus epidermidis from their skins or from patient skin into the prosthetic valve, and that will continue to live over there, grow slowly, and will again cause endocarditis. In case of intravenous drug users, we commonly see right-sided endocarditis. Now, one of you had replied that the death can occur if it is right-sided endocarditis due to pulmonary embolism. Why in intravenous drug users we see more of right-sided endocarditis, which is polymicrobial, which is because of Staphylococcus, and which sometimes leads to pulmonary embolism? Can anyone give any reason? Why right? If you see a patient with right-sided endocarditis, think and suspect if the patient is IV drug user. Why? Any guess? Anyone can answer that question? Link between IVDU and right-sided endocarditis.
Because veins drain into right side of.
Absolutely right. Absolutely right. The veins, intravenous drug user means the drug being injected in the vein. And the vein take their blood into the right side of the heart. So obviously, the bacteria are likely to go and get into the right side of the heart first. And if there is already a damage in the right side of the heart, then the bacteria will find the right place to get inoculated into. And why it could be Staphylococcus? Because Staphylococcus is commonly present on our skin, where the intravenous drug users are likely to inject. Why it would be polymicrobial? That means not only Staphylococcus, there could be other bacteria associated with it, because the IV drug users are not so careful in using antiseptic techniques and cleaning their skin with alcohol or iodine before injecting the drug. They are in a hurry. They are in a hurry to inject the drug quickly, surreptitiously, and during that process, they do not clean the skin, so they can get polymicrobial infection. Also, many of them do not use sterilized syringe and needles. They may use contaminated, repeatedly used syringe and needles used by someone, again used by this person. So not only they can get staphylococcal and polymicrobial, they can even transmit HIV, HCV, HPV, and many other infections from one to another because of use of contaminated syringe and needles. Drug users, intravenous drug users, it is very, very difficult to wean them off the drugs. The best way of not having intravenous drug user is not to take drug at all. Once a person gets hooked onto IVDU, it is very difficult to wean that person away. And those people are likely to suffer from endocarditis, likely to suffer from hepatitis, HIV, and many other infections. Therefore, if the attempt should be primarily to wean the person of the drugs. But if the person cannot be weaned of the drugs, at least ensure that he uses clean, sterile syringe and cleans his arm properly before injection, so that at least he or she doesn't get endocarditis and other infections. So you can deal with lesser of the evil, that is IVDU. You don't have to deal with the other problems which could be associated with it. So how will the patient present? Well, the bacteria have entered, got lodged, so we'll get all the features which we have seen in case of Purple Heart syndrome. Pyrexia of unknown origin, patient doesn't complain of cough, urinary problem or diarrhea or nasal discharge or nothing, no localizing signs. So we call it as fever of unknown origin or pyrexia of unknown origin. There could be general features like malaise, anorexia, weight loss, not feeling well. But one thing which will help you into earliest diagnosis of endocarditis, if you can put your stethoscope on patient's heart. If you hear a murmur and if the patient has fever, your first diagnosis should be endocarditis. So one simple stethoscope can give you a clinical diagnosis straight away. Patient complains of fever over a period of maybe few days or weeks. You hear a murmur, put two and two together, think about endocarditis. That must be excluded before you could think of anything else, because endocarditis can kill within hours. Patient may have anything else which could be cause of fever, but if you ruled out endocarditis, then anything else is possible. So look for general features, look for heart murmurs, look for septic emboli on the palms, soles and other body parts. Look for secondary sites of bacteremia. The bacteria would have gone from the thrombus, gone into some other site, maybe skin, maybe anywhere else, and could have led to bacteremia over there or could have led to metastatic abscesses over there. Look under the nails. The characteristic feature is a splinter hemorrhage, like the splinters which are there under the nail bed, under the nail, you'll see lines of reddish lines of hemorrhage. And sometimes you can get ossular nodes. But if you have missed out on these things and looking for ossular node, that's bad clinical practice. So look for these features: fever, general features, heart murmur, and evidence of thromboembolism. You will have 90% of the cases clinically diagnosed with these features. So this could be some of these splinter hemorrhages kind of a thing which you can see. There could be septic emboli, there could be painless reddish spots coming onto the palms or soles known as Genevieve lesions. There could be septic hemorrhages, emboli on the soles. Ask patient, did the patient walk barefooted to get something like this? If rest of the skin shows that the feet are very soft and supple, that means patient is not walking barefoot. And if patient has got lesions like this, think about endocarditis and embolism. Anywhere. It could be on the sole, it could be on the dorsum of the foot, it could be hands. Look at these peticulae. Or it could be extensive area of petechial hemorrhage. Now this can occur because when the thrombus formation occurs, many times all the platelets get consumed and there may be hypoplatelets, there may be thrombocytopenia, and which can lead to hemorrhages in other parts of the body. If your clinical suspicion is there, then it's easy to diagnose. Laboratory diagnosis could be for two reasons. One is to see the extent of thrombus, extent of vegetation, and second is to find out which bacteria could be associated with it. So if you do echocardiography, it will show you how much cardiac function is damaged. If you do further cardiac studies, it will also show you the size of the thrombus, the movement of the thrombus, and whether the thrombus is getting detached at any site and causing embolization. If you want to know which organism might be causing it, what you need to do is you need to do blood culture, at least 3 sets of blood cultures within a 24 hours period. And how do you do that? You take biphasic medium, you draw about 5 to 10 ml of the blood, making sure that you are not contaminated while collection. That is most important, because if you have contaminated the blood sample with the staphylococcus from the patient's skin itself or from your fingers, you may misunderstand and mistake it for pathogenic organism. So take blood culture, allow it to grow, subculture it from there, and identify the bacteria. Now this particular blood culture technique will be shown to you when you come over here in the practical laboratories, and this is one of the commonest ways of diagnosing any bacteria which are circulating in the bloodstream. Sometimes the bacteria which cause this infection are fastidious and therefore will not grow easily. In that case, we can do a serodiagnosis or we can do a molecular diagnosis by taking a blood specimen and trying to find out if the bacterial components are present or whether the antibodies to bacteria are present in that. How do you manage endocarditis? The bacterial infection needs antibiotics, which could be penicillin, clindamycin, macrolides, aminoglycoside, depending upon which type of bacteria are there. Usually it requires prolonged therapy because the bacteria are hidden under the thrombus. So antibiotics will not reach it easily. So you need to keep on putting lots of pressure on the bacteria by having the bloodstream flooded with antibiotics so that some antibiotic will percolate inside and kill the bacteria. But killing the bacteria itself is not solution, because thrombus may be a sterile thrombus, and on that thrombus further thrombus development may occur or embolization may occur, and therefore what is most important is early surgical resection of the vegetation. That means you cut out and remove all the vegetation so that it does not embolize. But unfortunately, and when you excise the emboli, when you excise the thrombus, when you excise the vegetation, you leave a raw area on which again new platelet deposit can occur and again can cause new thrombus, new vegetation over there. And therefore, the patient will require prophylactic antibiotics more or less throughout life. And the usual antibiotic we give is penicillin, because mostly streptococci causing endocarditis are sensitive to penicillin. Yeah, that brings us to the question. We had asked you one question. What is the dose of penicillin for prevention of rheumatic heart disease? And what is the dose of penicillin for treating sore throat? So prophylaxis penicillin and therapeutic penicillin for streptococcal infection and for prevention of rheumatic heart disease is required to be known. And similarly, we give prophylactic antibiotics to prevent further occurrence of thrombus, further occurrence of vegetation development. So surgical treatment, antibiotics, preoperative antibiotics and post-operative prophylactic antibiotics are important features of management of bacterial endocarditis and its consequences. So that brings us towards end of today's talk on bacterial endocarditis. We have solved the case of Purple Heart Sandra. What must have happened to her in childhood? What must have led to rheumatic heart disease? What must have led to vegetation or endocarditis? And what detachment or embolization from that vegetation could have led to her death? How we could have prevented it? How we could have stopped it from developing into rheumatic heart disease itself, or subsequently, if you had followed her up properly, you could have prevented endocarditis. She would have been acting in many more movies and entertaining us. But unfortunately, it didn't happen. It's our responsibility to make sure that children in our society, in our country, do not suffer from recurrent respiratory tract infections, and if they are, to make sure we diagnose that they are not having rheumatic disease. If they are having, treat, prevent occurrence of endocarditis. There is no point in trying to treat a patient after the patient has developed endocarditis. Our aim should be to prevent its occurrence altogether. So you'll find very interesting information on all these sites which I have informed over there. And the last one is the best one because it shows the best practices. And it comes from British Medical Journal, a very, very relevant topic discussion. So you can log into over there. You can sign in over there. You can sign in for free and you can have lots of information on various topics in medicine coming from there. So join in bmj.com, log in. You don't have to pay any subscription. You can be a non-subscription paying member and you can have access to not all, but some of the important contents over there. So that brings us to end of bacterial endocarditis. The likely questions from here, which could be there in your block test, is what is endocarditis? What are the cardiac factors leading to endocarditis? What are the non-cardiac factors leading to endocarditis? Why a particular valve or why a particular site of the heart may get involved into endocarditis? Which are the common organisms which can cause it? How can you clinically diagnose it? How can you confirm your diagnosis by laboratory investigation? How should you treat and what should you do to prevent occurrence of endocarditis as well as rheumatic disease? Any doubts? Any questions in anyone's mind? If you have, please feel free to ask. We would be happy to answer them. Meanwhile, we have already given you some assignments based on rheumatic disease and also on endocarditis. Make sure you try them, write your answers, share, get comments on your answers, and then be ready for your block test, which is going to be open book, open web, something which we did for immunology. So you'll have freedom to open the web and open the books and find out material and write, but you have to use your own language in your own hand and give answers. The questions are going to be tricky. You're not going to find ready-made answers to them. But if you have understood the subject, you should be in a position to answer those questions properly. Any questions? Any doubts? No questions? No doubts? Okay. So we'll discontinue because you will have some other class to happen. So meanwhile, take care, stay safe, enjoy, have fun, and keep studying also. Good luck. Bye-bye.
Thank you, sir.